serve here as the DG for Enfield. I just want to commend you all for the hard work you do in the counties. Commend you all for working under constrained conditions, limited resources, but yet and still, you still get the work done. So I'm extremely proud of you today. Excited to be here. Want to say thank you to our CDC partners, AFINET, for really being the mentor for this particular FETP training. This is the second cohort of medical directors, and we're seeing the work that the training is doing within the counties, giving you a new perspective on how to look at your data, how to review the data that is present, and how to really build your capacity within research and other areas. Being able to look at your data at county level and able to develop publications because of that. We are a research institute, and we're welcoming doctors that have data at the county level, and how we can look at that data together with the research team that's here, how we can get more publications that will actually drive policy for different healthcare facilities. That's how we drive policy. We look at the data, we interpret the data, and then we say, okay, this is what we found out. And because of that, we're able to develop new policies or new interventions for the way that we work. I know it's not easy, but I hope that you were able to get an appreciation for the kind of work that we do here at Enfield.
Our directors from the National Public Health Institute, our country director from USCDC Liberia office, and all other persons here and seated. You are very welcome. Happy to have you. So my role here is to give a brief overview of the Liberia Executive FETP. It's indeed my privilege to do so. I am the lead of the team that is on ground implementing this program, and that is why it falls on me to make this presentation. So since 2015, the Liberia FETP has been supporting the government to build capacity for public health service, particularly in the area of epidemiology, surveillance, outbreak response, and we have been very nicely rewarded with the outputs that we have seen from the program, and we are happy that we keep moving on and making more gains. So this program, the Field Epidemiology Training Program, was endorsed by the Ministry of Health, is owned by National Public Health Institute of Liberia, is funded by the USCDC, and is implemented by AFINET. So from 2015 way down to 2020, we started discussing the need to add another tier to the program. And this new tier, we thought, would add on to the frontline and the intermediate, which were already existing, and which were targeted at the frontline surveillance officers. We thought that this new tier would come in to focus on the managers of the various health systems in which these surveillance officers work, and who have overall responsibility for health delivery at the various levels: facility, district, county, national. And that this new tier would equip this group to understand what the principles of surveillance are, to enable them to mentor and supervise our frontline surveillance officers even better. We decided to call it the Executive FETP because we understand that this group is a very busy group. They may not have enough time to sit through the 3-month or the 9-month training at the front line and the intermediate levels, but we would repackage it in such a way that it's a much shorter course for them, and it's more convenient for them to participate. So this Executive FETP started last year, 2021, with the first group of medical directors. Now we decided, among the target group, we decided to start with medical directors because there had recently been a simulation exercise which highlighted a gap in case detection at the health facility level among the clinicians. And then one of our intermediate cohorts had also conducted a study which had revealed low knowledge of IDSR, Integrated Disease Surveillance and Response, among our clinicians here in Monserrado. And so we thought that it was a more pressing need to start with our medical directors, and therefore we did so with the first cohort in 2021. And here we are in 2022 with our second executive cohort. And this is made up of 14 strong, dynamic, very intelligent medical directors, whilst cohort 1 focused on directors from Monserrado and the surrounding counties. The rest of the country has been covered in this second cohort. So we have 40 medical directors coming in from Grand Cape Mount, from Bomi, Nimba, Bapolu, Grand Bassa. We have 2 from Lofa, Bong, Maryland, Grand Jide, Grand Cru, River Ses, River G, and Sino counties. So once they have been with us, our medical directors have gone through 6 weeks of training. In the first week, they stayed in classroom and learned the basics of surveillance, epidemiology, a bit about epidemiology, and we introduced them also to Microsoft Office, how to make their scientific presentations. Then from that, for week 2 to week 6, they went back to their workstations and implemented what we had taught them in that short 1 week in what we call the field work. So the field work was actually conducted at their own very health facilities. And they were required to first do an advocacy meeting with their staff to introduce to them IDSR and help them to understand the need for all of them to get involved in IDSR, the health facility, and generally to set a stage for the new phase of their leadership as medical directors more interested in surveillance issues at their health facility. So after the advocacy meeting with their staff, or during the advocacy meeting with their staff, they identified a surveillance problem. And together with their team, they worked on that surveillance problem. We taught them an approach to problem analysis called using the fishbowl. And so with that, they analyzed whatever surveillance problem they had identified with their team and came up with possible causes and solutions. After the problem analysis, they also went ahead to do an analysis of a 1-year data set on one of the immediately reportable diseases or events under IDSR in Liberia. All of them did it. And then at the end of the fieldwork period, they made a presentation on their findings, their experiences and their findings to the district or county health teams. And yesterday, we were privileged to also hear these presentations from our medical directors. Also in attendance yesterday were some officers from the national level. And so I think that it has been a very good opportunity for them to present a brief of what they have learned and also make their recommendations based on the work they did in the field. So today, just a few of them, actually 3 of them, will make brief presentations that outline some of the things that they have learned in this course, and just to showcase what it is they have done. However, their full presentations and their narrative reports and the recordings of the presentations they did yesterday are available for sharing. So at this point, on behalf of the training team has comprised officers from AFINET and the National Public Health Institute. And at this point, I'll kindly request that they stand and we applaud them for the efforts that they have put into the training of this So on behalf of this training team, I would like to say a big congratulations to Executive Cohort 2. We are very proud of you and the efforts you put into the training. Yesterday, it was really very gratifying to hear you present and share with us what the training has meant to you all. And we pray that going forward from here, you are going to make a difference in improving IDSR implementation at your facility and in the country as a whole. So thank you very much and congratulations.
Good afternoon. The FETP Executive Cohort 2 will be giving a synopsis of presentations, and I will begin. I am Dr. Sene Ovisuba. I'm the Medical Director for Bon Mines Hospital, and I'll be presenting on neonatal mortality data analysis done at the Bon Mines Hospital located in Bon County over the periods of 2020 and 2021. Bon Mines Hospital is located in former district. This is a border district between Margibi and Bon County. It was built by the German Concession Company in 1963. It is now managed and operated by the Ministry of Health. It is a referral hospital in that district. It serves a catchment population of 20,326. We are a comprehensive referral hospital. We have 4 departments. We do in and outpatient services with an average monthly load of 3,876 patients, and we have a capacity of 100 beds. Neonatal mortality by definition, according to WHO, is the death of a newborn occurring in the first 28 days of life. The known determinants are including and not limited to inadequate access to basic health care, congenital abnormalities, and maternal and fetal circumstances. Neonatal mortality is one of the reportable events under IDSR adopted by the Republic of Liberia, and our objective in the study was to describe neonatal mortality occurring at our facility according to person, place, and time. The data set was collected from the county's database of all the neonatal deaths that occurred in the hospital in the period of 2020 and 2021. We were able to use 5 variables: age, sex, county of residence, year, and cause of death, the variable place of birth, and mode of delivery of the neonates were not available to us to be used. The data was analyzed using Excel and descriptive analysis, and our findings were presented in bar charts. We had a total of 12 deaths recorded in the period of 2020 and 2021. The neonatal mortality rate for 2020 was 3 per every 1,000 live births, and for 2021 we had 5 per every 1,000 live births. The increase between 2020 and 2021 can be attributed to the increased referral from Kakata, which is in Margibi, which is the border county, the lack of an ambulance to refer our critical neonates to a tertiary intensive care, tertiary hospital. Neonatal deaths, we have 58.3% of our neonatal deaths being females. We had 70.5% deaths occurring in the first 24 hours of life. The cause of death was birth aphasia. 71.7 was the highest cause of death, followed by neonatal sepsis. 25% of the deaths recorded in our hospital of neonates were referred from the neighboring county of Margibi, and 75% resided in Bon County. Birth aphasia was our major cause of death, followed by neonatal sepsis. A majority of the neonates were from Bon County. Few were referred from Margibi County, which also contributed to the increase of our neonatal mortality that we saw in the year 2021. We identified a health facility surveillance focal person requesting additional training in IDSR and FETP so that those missing variables can be captured and recorded and placed on the line list for further surveillance purposes, and we shared our findings with the hospital and the senior staff. We are recommending that neonatal deaths and births should be recorded either in the patient chart or the neonates should have their own chart. A neonatal intensive care unit is urgently needed in our facility. The provision of an ambulance to be able to transport our patients to tertiary hospitals also needed, and improvement in the variables on the land list The mode of delivery, the place of delivery of those neonates are also recommended to be placed in the land list by Ministry of Health and MPhil. I will start here, and the next presenter.
Good morning. Good morning. I'm Dr. Jude Wieser, Medical Director at Martha Memorial Hospital, located in Steubenville, Grand County. Permit me to give you an insight on data duplication problem analysis at our hospital. So data quality stresses the level of accuracy and completeness in the data and reflects the reality leading to better public health action. This first statement served as an initial to the discussion. And through the discussion, we identified patient records obscure the reality of the data generated at our hospital. This brought the importance to trigger the problem analysis. This now brought us to identify the causes of data quality at the hospital and to improve data quality. Martha Memorial Hospital is located in Grand County, Chien District. We have a catchment population of over 16,000, that is just Chien District, not the whole county. And on a monthly basis, we see around 5,000 patients. The medical director, the ward supervisor, the data clerk, the record manager, and the hospital supplement officer constituted the population of this study. We did brainstorm to identify the causes of the problem. We categorized all of these problems on 4 broad categories and labeled them T for totally under our control, P partially under our control, and N not under our control. So we used the fishbone diagram as a tool to analyze these problems. From the discussion, everything pointed towards the duplication of patient records. This hospital has 4 unique outlets in issuing numbering system to the patients. So for example, if a patient goes to the ER, one unique system of numbering is given to the patient that must start in 100. And they go to the OPD, maybe another unique system that must start in 1,000. This causes the duplication of the record. We have limited filing space in the record room. So most of the charts at the end of the month that come from the different wards are not filed properly in the storage room. Because of that, at night, if a patient comes, the chart cannot be found in the record room. And the easiest way out is to open another chart and give another unique numbering system to the patient. We have irregular power supply. We depend on a national grid from Côte d'Ivoire, and we also have a generator that we cannot power because all of these, the budget dependent. So because of that, the record room at night might not have current. And at night, they cannot find the patient chart. And this also will lead the physician or the clinician to open another chart and give another number. We have limited stationery, which is also budget dependent. So normally we print these forms that have the bio data. So if these forms are not available, the clinician can just take a plain sheet, write the patient number and the name, and continue the string. To compound this issue, it's the patient himself. So most times they come with no hospital card. And if you ask them, have you been here? They tell you no. And if you really check the record, they've been there probably 2 or 3 times. So this again will cause us to open another chart. So if they went to the OPD, that's another number. If they came to the ER, that's another number. Then the staff attrition. Because of the moratorium on unemployment, there are limited staff to be assigned to the record room. So this gives us difficulty in running 2 shifts at the record room. And this also contributes to the limited staff. Incomplete data, this comes from, though it's totally under our control, but it comes from the staff. They are uncooperative, so for example, every ward has a ward supervisor. If the ward supervisor is absent, nobody wants to take the initiative to record the data or to carry the charts for filing. But this is under our control and they are uncooperative. So all of these problems pointed towards duplication of the record. And we think that if we synchronize the numbering system, we are able to solve 80% of this data duplication. So we then recommended to the administration to try to synchronize the patient numbering system, that ward supervisors should be encouraged to collect the appropriate data, and we urge The Ministry of Health will continue to engage the government to reverse the moratorium on employment so that the facilities can be properly staffed. Thank you.
Dr. David D. Morva, Medical Director for Saclay Comprehensive, Nima County. I'll be presenting on our experience as cohorts in the FETP workshop. This has been an intensive 6 weeks for us as directors. The workshop is actually demanding. For the 1 week we spent in the classroom, it was like going back to medical school, and it was time consuming. You can't come to this workshop and just do it passively. But the good news is that after all this classroom, headache, tough time here and there, we learned something. The workshop is very, very much educative. The way we came, we are not going back the same. Our knowledge in RDSR has increased a lot. Prior to us coming for this training, some of us didn't even know what was RDSR. But we are living with better knowledge when it comes to RDSR. And even during this time of training, we noticed that from just seeing data here and there, we noticed that we are sitting on a lot of data within our facility, that we could use this to make better decisions. So from this training, our knowledge has increased in research, and we promise that we are going to work on these things to make the health system better from our facility and even that we are large. Our skills, even of supervising the surveillance focused person, the DSO, and that of all the surveillance people within our facility going to improve. Because at first, reports will only come to us, oh, there's the surveillance data for this month or for this period, and we sign. We didn't even know what we were signing when it comes to surveillance. But I tell you, from now on, reports are going to be critiqued, going to be verified, and we will now know what we'll be sending to a national level. With the issue about the reports even going, the quality of the report. So last year I just decided to go through some of my previous PowerPoints and some of the Word documents. I was laughing at myself because the changes that I saw, the mistakes that I saw in those previous PowerPoints as compared to the ones that we are now preparing, is just so much. So our Word, our documents that will be presented from now on now, it will be better because of this training. And this will create a strong team. Because at first, surveillance was just seen as for the surveillance focused person, for the district surveillance officer, or for the county surveillance officer. Now with the knowledge gained as directors, we are now going to engage our team members that this thing is got to be a team. And since we are the leaders, we are now going to sell this idea to the entire facility. So the inclusion of everyone going to bring better results as compared to before. Having said all of these things, these nice things, it wouldn't have been possible without the help of the following organizations. So we want to recommend to MOH and that of NFIL that the training that we have received, it shouldn't just stop at our level as directors. We want this training to be extended to our CHOs. It should be extended to all our doctors that are formed within the facility and the general practitioners. It should even be extended to our PAs. And there are issues where staffs are replaced. For instance, the surveillance focused person at my facility is not training RDSR. So if these issues come about, it should also be able to be trained. So we are recommending this. And we have issues where lab specimens were collected from our various facilities and we didn't receive results. So as directors, we are recommending that results that will be sent will be a negative result, being a positive result. The train of information back to our facility, we should be included in that train of information. And we have issues about logistics. There are some facilities who do not have files, forms, and so on. We are talking to MOH that these forms should be always available. Staff attrition, staff that are leaving, replacing these staffs, they should also have surveillance knowledge. If not, it will affect the system and it will also affect the data quality. Coordination between the M&E officer and that of the medical directors, Any information that is leaving from our facility, I should be informed about it before it can be sent to county level so I can be able to verify. Thank everyone, because what we have gained within this 6 weeks, it is massive. We want to say thanks to MOH for giving us this opportunity that we are able to go through this screening. We want to say thank you to MPhil, to US CDC, affiliate to our county health team, to our hard-working mentors. There were times I was afraid to send my mentor message in the middle of the night thinking that he'll be asleep, but once I send it, his response will come right away. So they are pushing us. Some of us were lacking behind, but they pushed us that we are at this point today. And seriously, we are proud of ourselves. And even our hospital administrations, while we are not at the county level, we are intern going through this training, they are there supporting us. So we want to say thank you to everyone and thank you all.
It's very wonderful to be with all of you today on this momentous occasion to recognize your accomplishment. Thank you for giving me an opportunity to address you and to share a few remarks. I'm sure it's not new to you, the story of how FETP came to Liberia. I'm sure you're aware that FETP has been successful. I think Dr. Maming has remarked on this even just this morning. In many years of training individuals to be surveillance officers at district and county level. What's most important about the legacy of FETP in Liberia is that Liberia decided that they were going to stand up as part of the response to Ebola, a platform for training public health leaders in Liberia that had never been done before. They brought frontline and intermediate FETP to Liberia in the midst of a very challenging time of public health response. And the solution that presented for dealing with the Ebola response is something that I think we can all be proud of. But I think what we can be even more proud of is that that solution was durable and has lasted far beyond the Ebola epidemic. And I think that's the true testament to the value of FETP. It's one thing if it helps resolve the crisis of the day. It's another thing if it's still around for the crisis the next day, and the next day. And if you haven't realized it, much of what's being done in Liberia right now to solve the COVID-19 pandemic is being done by people who went through the FETP program. So I think for that, we should be very thankful. The other thing I want to say directly to those of you who have chosen to go into the executive program is actually to build on what Dr. David Mulba remarked on. Actually, I hope that you get a recording of your remarks. They were perfect. They were perfect. What you said about in your presentation about the value of this training for you as a clinician, for your facility, is exactly the model that we want people to understand that the executive FETP is meant to accomplish. I really can't build much on what you said, but I do want to appeal to your colleagues that are not in this room, who may not have the benefit of going through an executive FETP, to understand that as a doctor, I'm a doctor, you all are clinicians as well. We went to medical school and we were trained to learn to teach one person, treat one person. We received all these tools, the tools of physiology, the tools of pharmacology, the tools of interventions like surgery, radiology, to try and treat the problem that's in front of us with that patient. Through the executive FETP, through the intermediate and the frontline FETP, you as clinicians now have more tools to do what you need to take care of the patients in your facilities. And I think you should feel strengthened and encouraged that you are now better equipped to solve not only the problem of the person sitting in your chair in the consultation room, but the problems of an entire health facility. And when your surveillance officers come to you, and I think, again, I appreciated that you said this in your remarks, when your surveillance officers come to you saying, we need to address this, the trends in this area, in this ward, or in this segment of the community look like this, listen to them. Help them think through the process of doing the fishbone analysis, doing the outbreak investigation, thinking through the problems and the contributing factors so that you can resolve them. And then Tell the story to your counterparts in other facilities, in other communities, districts, even your counties, so that those problems and those lessons learned can be replicated elsewhere. So again, I thank you for the investment of your time, for being pioneers at the start of this program, and I congratulate you on your success.